Okay, for this week, we are going to be doing views of the lower leg and the knee. For the lower leg AP view, the patient is going to have their leg in an AP position. Obviously, I would not have them have any pants on. I would ask them to, gown up if I needed to, and make sure there's no any types of jewelry or anything that would be in as an artifact in the view. I would also tell them during each exposure to not breathe or move, and then I would collimate to the smallest size that I could to make sure that make sure I'm getting all of the structures, and I would also use Mitchell markers to distinguish which leg or knee I am taking. So for the AP, also this is going to be at 40 SID, and for an AP tibia and fibula view, if we're using a tabletop, we're going to actually include both the knee and the ankle joints in this. So we would have a 14x17 cassette that would be diagonal. And then if they're standing, then we are not going to be showing both of the joints. And we would just want to include the joint closest to the injury or the trauma. The central ray for this would be going perpendicular to the shaft through the center of the field. So it'd be about going through here, this way. Their leg would be extended, and we would want to be looking at the tibia and fibula as well as the knee and ankle joints if we can get that in the view. And then for our lateral tibia and fibula, so the patient's going to rotate, or we're going to rotate them toward the affected side laterally. So we could have them rotate this way, if that's the affected side, so we can get their leg into a true lateral position. And there is a line through the femoral epicondyles, and they're perpendicular to the film plane. Again, if they're on the tabletop, we're going to include the knee and the ankle joints on a 14x17 cassette. And same thing with standing. We're just going to if they're standing, we'll get as close to the trauma as we can. The central ray will be directed perpendicular to the shaft as well, through the center of the film space. So it would still be going through here on that. And we still want to see the tibia, fibula, and the ankle and knee joints if we can, but obviously it would be in a lateral projection. Okay, for the knee views, we are at 40 SID. We're going to collimate to the appropriate size. Probably going to use a 10x12, so then we can place the central ray in the appropriate spot. But before I explain that, we're going to have the patient fully extend their knee. This can be taken either standing or recumbent. And then we want them to internally rotate the leg approximately 5 degrees, so the patella is centered over the femur and parallel to the film plane. The central ray is going to enter a half an inch below the apex or the bottom of the patella. So here's the patella, so it's going to go a half an inch down, and if they are recumbent or laying down, then we're going to angle the central ray 3 to 5 degrees, because they're going to be, if they're laying down, then the joint space is going to be different. So, but if they're upright, you may not need to angle. So, either way, though, the central ray is a half an inch below the apex of the patella. We're going to want to see the projection of all the bones and soft tissues of the knee, including the distal femur and the patella. We'll want to see the proximal tibia and fibula and the inner space between tibial plateau and the femoral condyles. So we should be able to see the lateral and medial epicondyles and as well. And that is it for the AP knee projection. For the medial oblique knee view, patient is also going to be having their leg extended. It's going to be the same thing for the AP view. If they are recumbent, you will most likely need to angle the central ray 3 to 5 degrees. But if they're upright, the central ray is going to be perpendicular. It will be perpendicular to the film. Big one though for medial oblique position is we want to rotate the leg 45 degrees. So if you can tell, it's not just the foot, because that's not going to rotate the knee. We're going to want to rotate the whole leg medially at the hip joint. So, and that's at 45 degrees. And then the central ray though will still go a half an inch below the patella. And we'll use a 10 by 12 to place the central ray. And we should be able to see all the bones and soft tissues of the knee, including the head and neck of the fibula and the proximal tibiofibular joint. And that's for medial. For the lateral oblique position, patient's knee is still going to be extended, and we're going to rotate the leg externally 45 degrees. Remember, the whole leg. Still making sure the central ray is going a half an inch below the patella, and still the same thing. If they're recumbent, we may need to angle 3 to 5 degrees, and then upright, central ray is perpendicular, but it's still half an inch below. For this one, the anatomy that we should see, since they're laterally rotated, we'll see the femoral condyles, the patella, the tibial condyles, and the fibular head and neck for that one. Okay, so for lateral knee, patient is going to have to turn towards the affected side and place the unaffected leg behind the affected leg to try to make sure that the knee is in a true lateral position. And there's a line going through the femoral epicondyles that's perpendicular to the image plane. So for this, we're going to need the patient to flex their knee 20 to 30 degrees. Making sure the long axis of the femur is parallel to the bucky. This is, hopefully you can see that. So 20 to 30 degrees, and then the central ray will be on a 10 by 12 image receptor. And same thing, a half an inch below the patella, the bottom of the patella. And then we'll have to use that to center it to the bucky. The central ray might have to rotate 5 degrees cephalic to the knee joint, so we can see the joint space. But it's still going to be a half an inch. The central ray is still going to be half an inch below the medial epicondyle. You should be able to see the lateral distal femur, the patella, the joint space between tibial plateau and the superimposed femoral condyles. You should see the proximal tibia and fibula, and then the adjacent soft tissue and the open inner space between the femoral condyles and the patella. And that is lateral knee. So for this view, patient is going to be P to A with their knee as flexed as possible, They would look like this, and we're gonna have to angle this view. Patient is going to be standing P to A, or they can also be prone as long as their leg is P to A and the femur is parallel to the plane of the film and the leg is flexed, like at least 40 degrees. So the central ray can be perpendicular to the lower leg, and it should be exiting a half an inch below the patella. So the central ray would be going through this part of your leg. Hopefully you can see. To be able to do this, you're gonna have to play with the collimator and just see how you can get that central ray there at 40 SID. And then you should be able to see the intercondylar fossa, the distal femur, the tibial spine, the tibial plateau, and the knee joint with this view. Okay, so I'm gonna finish explaining the tangential patella view, not laying down. So basically with the knee flexed, we want to make sure it stays that way. So if we need to use something to stabilize it, we will. We're going to angle the central ray 45 degrees cephalad to create a 10-degree central ray angle since they're laying down and their knee is bent. But the central ray would still go a half an inch below the bottom of the patella, and it would still be at 40 SID. So we are able to see the patella and the space between that and the femur. We would not do this position if there is a potential fracture of the patella. We would look at the lateral view for that. And then also, if the patient cannot go into a P to A position, we would probably use something like the Setagast, if that's how you pronounce that, because they don't necessarily have to be P to A for that. We would just use a different method. So that is all for week 7.